And I would like to introduce Dr. Mackenzie Fowler from University of Alabama at Birmingham. And she's a PhD candidate in epidemiology. Her dissertation is focused on the effects of cancer history on cognition in dementia. She aims to examine health disparities in these associations, including racial, social, economic, and geographic disparities. And the presentation title is Geographic Disparities in County-level Prevalence and Incidence of Alzheimer's Disease across the United States. So you're very welcome. Mackenzie, please, you can start your presentation now.
Okay, can everybody hear me and see my slides?
Yes, we can hear you. We can see your slides. Thanks.
Okay, so thank you all for inviting me to speak today, and of course, thank you to everyone who's tuned in and listening. I'm actually defending next week, so I we'll be finished with that, and hopefully can delve into this a little bit more as a postdoc and a faculty member in the future. So I'm going to go ahead and get started. Well, if my computer will, okay, there we go. So I don't really have anything to disclose. These data are unpublished, but we are looking to publish them in the not so distant future, so be on the lookout for that. So small area geographic disparities in healthcare delivery have been observed across several disorders, including but not limited to stroke and cancer. But today they are poorly understudied in Alzheimer's disease. A previous presentation mentioned doing county level estimates of Alzheimer's disease, and that's what we're doing here. So I think that's a nice segue. So we do have national and state estimates of Alzheimer's disease prevalence and incidence, but we don't have estimates on smaller geographic regions like the county or even the neighborhood level. So investigating these would really provide opportunities for us to tailor our interventions and our programs to specifically focus on populations where the prevalence and incidence seems to be higher and rising. So previous studies have shown that there are low diagnosis rates for Alzheimer's disease in primary care, and multiple factors have been posited to contribute to these delays. Specifically, people may not recognize these symptoms as something that's a problem. They may just attribute it to getting older. Patients and caregivers may simply fail to recognize anything's wrong at all. And then patients may also just simply refuse to seek care. But one of the biggest things is lack of access to care that may contribute, particularly in rural areas and for minority groups. So in addition to the prevalence of delays in diagnosis, we know that delaying diagnosis is also associated with increased costs to the healthcare system, the patient, and the caregiver. Whereas earlier diagnosis results in more effective pharmacological treatment and therefore decreased burden both financially and otherwise to the patients, their caregivers, and the healthcare system. So we wanted to examine this and identify areas at risk by looking at small area geographic disparities. And we did this by looking at the estimated prevalence of Alzheimer's disease and the rates of actual diagnoses across counties throughout the United States. And then we compared the two. So to do this, we used CDC Wonder data to get the population totals and the mapping. And then we used incidence and prevalence estimates from the Chicago Health and Aging Project, or CHAP. And then we obtained the diagnosis rates from a 5% Medicare sample that spanned from January 1st, 2018 to December 31st, 2018. So the outcomes that we looked at were the incidence of AD, I don't know why that says dementia, in the sample for CHAP, and then the prevalence of AD in the sample for CHAP. And then in Medicare, we looked at the prevalence of actual diagnoses in the sample. So the exposure was just simply the county of residence in the United States and we really looked at these maps visually and compared the geographic distribution. I do have a few quantitative data points later, though. So as far as analysis, we calculated the incidence and prevalence estimates from CHAP by age and race groups, and then we extrapolated those to the population totals from CDC Wonder, again, by the age and race groups. And then we summed those across the age race groups to obtain the total incidence and prevalence by county. And then we converted that just to a rate per 1,000. And then we mapped these using county FIPS codes across the United States. For Medicare, we just simply looked at the prevalence of 80 diagnoses per 1,000 beneficiaries for each county across the US, and then again, mapped them by FIPS codes. We also broke these maps down into Blacks versus whites as well. And then we just visually compared the maps of Medicare diagnoses to those obtained from the estimates in CHAP. We did all of this using RStudio. So in CHAP, these are the estimates of the estimates of Alzheimer's disease across the United States that we extrapolated from CHAP. So we see that the estimates for prevalence and incidence are higher in the Southeast and the Midwest. You can see, let's see if I can move my mouse. Okay, so you can see it's a lot darker down here in the Southeast and in the Midwest. And you can see that similarly over here for incidence. And then you can also see that it's a good bit lower in the West, with a little bit more purple peeking through in the Western United States. So you can also see that for prevalence, there's several hotspots, and for incidence, there's several hotspots. And you can see that there's a little bit of difference in the incidence map. And so there's some hotspots for incidence where the prevalence may be lower, but in the coming years, as the incidence continues to increase, the prevalence would also be expected to increase. So looking at the Medicare, this is the Alzheimer's disease diagnoses, the prevalence of actual diagnoses across the United States. And you see a similar pattern. You see that the Southeastern United States and the Midwest has a lot higher prevalence, and then it's lower in the West. But the big difference here is that the magnitude of these results is attenuated compared to what we would estimate. So now we can see this even a little more clearly when we look at the prevalence rate of the estimates versus the prevalence of the diagnoses. So despite the similarity in the pattern, there are differences in these two maps. So particularly in the Southeast, the rate is at its highest in the estimated map, and it's similar in the observed diagnoses, but it's a lot lower. And then you see that similarly in the Midwest. And then you see the lower rates in the Western United States. So to put this a little bit more in quantitative terms, across the United States, the median estimated prevalence was 127 per 1,000, but the median prevalence of diagnoses was 90.3 per 1,000. So then when we look at this by race, the bottom map here is just the overall map that I just showed you. And on the top left, we see that the prevalence rate in the Southeast, so the top left is whites, and then the top right is Blacks. And we see that the prevalence rate in the Southeast may actually be driven by the rate in the Blacks. So this isn't super surprising, considering there are a higher proportion of Blacks residing in the Southeast, but also they're also at more risk of Alzheimer's disease. Looking at incidence, we see a similar pattern where the Blacks may be driving the incidence rate, the estimated incidence rate. So looking at this in Medicare, we still see this similar association. but the results are still attenuated compared to those we see in the estimates from CHAP. So looking just specifically among whites, you can see that the rates are still attenuated a little bit better than just looking at them on separate slides. And so again, just to kind of quantify this, the median estimated prevalence among whites in CHAP was 109 per 1,000. But the median prevalence of the actual diagnoses was 71 per 1,000. So that's a pretty big difference in what we're estimating and what we're diagnosing. Among Blacks, you see something similar. In Medicare, unfortunately, we had to use non-whites because the race was not as great as in CHAP, but we still see the attenuated results regardless. And so quantitatively, the median estimated prevalence was 4.5 per 1,000. And the median prevalence of diagnoses was a little bit higher actually at 6.4, but since this was in all other races, in Blacks specifically, the observed diagnoses may be even lower than what we were seeing for the difference in estimated and observed for whites. So to conclude and to kind of summarize what all of this means, again, the estimated and observed prevalence of Alzheimer's disease seems to be concentrated in the Southeast and the Midwestern United States, but a good bit lower in the West. So the estimated prevalence in CHAP shows only modest similarities to the pattern of the diagnoses in Medicare. The observed diagnoses are attenuated, as we saw visually and quantitatively, and this is those previous reports indicating missed or delayed diagnoses. So furthermore, the predicted prevalence of Alzheimer's disease seems to be higher in the Southeast in Blacks. And this is consistent with the rates of AD in Blacks being higher, but it doesn't seem to translate into higher diagnoses. So again, going back to the missed or delayed diagnoses, they may be more common in non-whites. This is not terribly shocking because we know that primary care is higher among rural areas, as well as access to care issues in minority groups. The estimated prevalence, unfortunately, is just that. It's an estimate based on CHAP, and it's not the actual prevalence based on diagnoses. And this kind of indicates to us that we're not very good at estimating Alzheimer's disease. So we had to extrapolate these from a small geographic study where CHAP is just in Chicago, and Chicago probably doesn't represent the rest of the United States very well. We're also not very good at diagnosing Alzheimer's disease. So improper coding might skew these estimates. And individuals with AD, they could have been diagnosed with dementia not otherwise specified, which would be more common in Blacks potentially because they are more likely to present with an atypical Alzheimer's pathology. Put a question mark there because I don't know that for sure, but I anticipate that might be the case. So looking at these areas at risk, we can really identify these areas that are more poorly diagnosing Alzheimer's disease and target our public health interventions to these areas, particularly looking at racial and socioeconomic differences that may drive the differences in these areas. And then further diving into that and looking at if Blacks are more likely to be diagnosed not as Alzheimer's, and looking at, are they being seen more in primary care, and is that the issue that's going on here? We do need association studies of this. So some limitations, as mentioned in the prior presentation, mapping at the county level, specifically by race in particular, is imperfect. there are low sample sizes in many counties throughout the US for minority races. So in the Midwest, there typically is not that many African Americans. The observed prevalence is from CHAP, and it's based only on AD, not on dementia NOS. But if we looked at dementia NOS, we would not really be getting AD there either, because there would be other people diagnosed with other dementia subtypes. So we would really have to find a way to tease this out. And then notably, of course, the ecological fallacy, just looking at this visually is not enough. We do need association studies to examine these, the drivers of this association and what's going on here. So I want to thank my collaborators, Dr. Richard Kennedy. He, his grant, his R01 provided the funding for this. He's also my research mentor. Dr. Michael Crow, Dr. Huifeng Yoon, who did a lot of the Medicare quantification, and Dr. Mei Li also worked with her on that. My fellow student and peer, Christina de Blasio, and of course, the participants in the Chicago Health and Aging Project for their data and their estimates. Thank you again for having me, and I am happy to take questions.
Okay, thank you very much. Thank you very much, Mackenzie. And we have plenty of questions for you. So please be prepared. So question number 1, will you expand upon why the estimates are attenuated for the Midwest prevalence rates in the 5% Medicare sample?
I will go back. So let's look here. So why the rates are attenuated in the Midwest, considering the fact that there are more whites in the Midwest typically. Well, the Midwest is very rural as well. I don't know for sure what's driving that. I anticipate that there's probably a lot of primary care out there, and maybe they're just missing those diagnoses. I also think that we should probably examine rural attitudes towards seeking care for things like Alzheimer's disease. You know, a lot of people are stubborn, and I think some of the people in the Midwest are kind of similar to the people here in the Southeast. They're like, oh, there's nothing wrong with me, or they are just kind of stubborn and don't want to go to the doctor. Also, looking at provider attitudes and provider comfort with sending someone to a specialty physician. Maybe they don't exactly know what's going on with that person, and it's not presenting exactly like Alzheimer's disease, so they're afraid to call it that. I think that might be some of it, but I don't know for sure.
Okay, thank you. Thank you very much for your response. So we have another question. How do you know there were missed or delayed diagnoses?
I don't know. I am attributing this to the literature that says we are missing or delaying diagnoses in primary care. Considering the fact that we have had to do our estimates based on a small geographic study, we may not be. But this kind of furthers the point of we need national studies on small area geographic disparities. We can't just be really trying to examine this based on an extrapolation from a small study. We need to look at this at the national level, like so many other studies have done with cancer or with stroke. The REGARD study has done really good at nationally estimating stroke on the small county level. So we really need that kind of a study. Of course, that's not something that's going to happen overnight, but you know, we may not be missing or delaying them, but that's what it seems like based on our estimates. So I agree with you. Whoever was that asked that question, I agree with you. But
that's from our audience questions.
It really does point to the need for us to really study this on a more granular level.
Okay, thank you very much. And we have another question from the audience. With regards to small geographic regions, you use the county level data. What is your recommendation for even smaller geographic regions to estimate the prevalence and incidence? What type of data would relate the geographic prevalence and incidence to delivery of services? As you mentioned, was the reason to look at the small geographic region.
I'm going to read this question too, just because that's kind of a long question.
Yeah, that's long.
Yeah, so that's a good question. So smaller than the county level would be more probably the zip code or the census tract level. That will be even more difficult because in a lot of areas there won't be minorities. Even more so, there may not even be people with Alzheimer's disease in those areas. It gets really small, especially as you get up into kind of the Northeast. Some of those neighborhoods are quite small. So that would be the goal, is to go even smaller if we can. I'm not a GIS expert, but I think that would be the next step. So what type of data would relate these to delivery of services, as you mentioned? So I think what we would have to do is, look at provider specialty. So what is the prevalence by provider specialty? Are the primary care providers actually doing a good job, or are the people who are being diagnosed at these small levels being diagnosed by specialists? Based on my experience here, UAB is kind of in like the biggest area of Alabama, and we have people come from all over the state for Alzheimer's care, but we're missing a lot of people. And for some people, the big area that they would go to is, not that big and probably not that good at diagnosing or referring someone if they're having more difficult issues. So I think the first step would be to look at provider specialty, and then to look at the costs as well. Who's spending more money, and where are they spending more money? Is it in the rural areas? Is it in the metropolitan areas? I don't know, but I think we do need to relate that back to that. We did think about doing provider specialty in Medicare. Going to be a little difficult considering the coding in Medicare for that, but we do need to look at that. I agree.
Okay, thank you very much, Mackenzie. And I think we have a little bit more time. So I have another question. Did you check the patterns of incidence and prevalence for dementia? So other forms of dementia, or for stroke, for example, using the same approach?
No, we did not. So that was one thing that I was talking about with the dementia NOS. I think we could do that, but you're going to be getting other subtypes. So we're not going to be able to say, okay, let's compare this to the rates of Alzheimer's disease. Maybe looking at the difference. So in absolute terms, or in quantifying terms, looking at the median difference between those two would tell us, okay, are these people being captured in dementia NOS, or are they being captured in, or are they not being captured at all? So I think that's one thing that we could do. Looking at other dementia syndromes as well. If we were to look, for example, at dementia with Lewy bodies, or vascular dementia, we don't really have estimates of that either. So we're still probably going to be drawing from a small sample to compare to, or to extrapolate back to the United States. And so we would end up with some of similar issues. But that is also something that needs to be done, particularly with vascular, because it's frequently mixed with Alzheimer's disease and sometimes a little bit hard particularly in Blacks, to kind of tease out what's going on. So they may not even be diagnosed as either one of those.
Okay.
Sorry.
Oh, you want to add something? Okay.
Well, and we couldn't look at incidence in Medicare, and that's something that's a problem because, you know, we didn't have, you know, how long they'd been followed in Medicare. So that's also something that we probably should look at in a more nationally representative sample as incidence rather than just prevalence.
Okay, Mackenzie, thank you very much for this presentation, and we all wish you good luck with your PhD.
Thank you.
We hope everything will be fine, and thank you again.
Thank you.
I think it could appear at the bottom of the screen, the pool, new pool. I cannot see it right now, but it could be here. So please, the audience and panelists, if you will see the pool at the bottom, so you can use this pool and answer the question. And so I still do not see this pool. Oh, that's it. Okay, so now we will answer this question, and then we will move to the last presentation in our session.